Thank you very much for the nice introduction. Good afternoon. Thanks very much, especially for the invitation to be here. It's a great pleasure to come to Melbourne. And coming all the way from Rotterdam, I realized that, in fact, Melbourne and Rotterdam are quite similar because they both have great modern architecture, they are multicultural and have a lot of water, and even the weather is as unpredictable. Today there was a huge shower here in Melbourne. So they are also as different as day and night, in fact, quite literally, because when it's daytime here, it's night in Rotterdam, and for me, it feels a little bit like night at the moment, to be honest. So today I will talk about benefits and challenges of translating preclinical studies into clinical practice, and I will talk also about translation from mice or rats to human beings. And even though we have 97% of our genetic material in common, these animals can be different as day and night from us as well, as we can only see from the exterior already. But nevertheless, we can obtain very useful data using them. So I will focus on radiolabeled somatostatin analogues, and we have seen this list over and over again today, with DOTA-TOC and DOTA-TATE being most widely used in the clinic, and also the antagonist being very, very interesting, coming up in clinical studies now. And all these radiopeptides are based on the same fission. It's a simple fission. Let's take a peptide with a high affinity for the receptor, attach a chelator, perhaps a linker in between, label it with a radiometal, and you have your tracer for imaging and for therapy. But we have to realize that not only the peptide sequence, but also the radiometal and the chelator and the linker can all influence the receptor affinity and the pharmacokinetics. So for each combination, we have to test if these tracers still adhere to the tumor characteristics of the ideal tracer, the characteristics of the ideal tracer, and that is having a high binding affinity. Probably you cannot read it, but it's here. High binding affinity, high specific activity, high peptide stability, and a low toxicity profile. So this has to be evaluated prior to human application. In models, it should be as representative as possible. So we aim also in the mice for tumor models that have a good behavior. So there should be a high receptor expression, as seen on the right, high tumor perfusion. If the peptide is not delivered at the tumor site, there will be no uptake, even though there's a high receptor expression. There should be a high tumor-to-background ratio and very favorable pharmacokinetics. So what we study in preclinical studies is this cycle of research. We start in the left upper corner with target validation and binding of the tracer. And we most often do that on tissue sections, very often of human material, where we test in autoradiography studies the affinity for the receptor. And then we move on to in vitro studies in cells. And for the tracer, we can test the target affinity, internalization properties, and retention properties, whereas for the model, we can get information on target expression, the density, and also the radiosensitivity for radionuclide therapy studies. And if all is favorable, we can start in vivo studies in small animals, and we have these beautiful imaging machines now, so we can image a mouse and a rat like we can image a patient. And from these in vivo studies, we should at least get information on the pharmacokinetics and the short-term toxicity according to the microdosing principle. And if all is okay, we can start clinical studies. And very often, from the clinical studies, new questions are arisen, so we go into back translation. We go back to the animals and find solutions for instance, reducing uptake in normal organs, or we even go back all the way to the target and find ourselves a better target. So a little bit in more detail on the role of in vivo animal studies. These can be used to determine the biodistribution, so the uptake in a tumor versus the normal organs. We can look at the tumor to organ absorbed dose in the therapeutic setting. Those limiting organs can be determined, as well as the maximal tolerated administered dose. We can look at the pharmacokinetics to see what the body does with the tracer, and also to the pharmacodynamics, so to see what the tracer does with the body. But of course, animal studies can never replace patient studies, and we have to be aware that animals and patients are not the same. So there are quite some challenges. So there's huge differences in heart rate, metabolism, clearance rate, much faster in these small animals than in the patients. We have to be aware of species differences with regard to receptor affinity. So we should avoid having a nice tracer that binds only to the mouse receptor and not the human receptor. Or we think we have an excellent tracer with no uptake in normal organs, but it's simply because there is no affinity for the mouse receptor. We have seen examples for that. So these small animals often have more easily saturation of the receptor, so we need high specific activity. Anesthesia can really influence the physiology in the animals and can mask all kinds of findings that we have. We should realize that these animals often are immune deficient, so how important is the immune system for the therapeutic response, and also the tumor proliferation rate can be quite different in these preclinical models. Nevertheless, there's quite some successes in translation, and I will show you two examples. They are quite old. I will show these not because we have no better, more recent examples, but just to show how happy I am that I was privileged to be part of early developments in the field related to the somatostatin imaging, receptor imaging and therapy. So this was the period when we realized that tyrosine 3 octreotide and tyrosine 3 octreotide had a better uptake in tumors in rats, and also the better tumor-to-kidney ratio. And this led us to the introduction of both compounds, and especially the octreotide, in the clinic. And we all know, of course, that both DOTATOC and DOTATATE are widely used now, both for imaging after labeling with gallium-68, mostly for PET, and for radionuclide therapy, mostly after labeling with yttrium-90 or lutetium-177. Both beta particle emitters, with a difference in that the beta particles emitted by yttrium-90 have the higher energy, 2.3 MeV versus 0.5 MeV, and a longer range in tissue, 11 millimeters versus 2 millimeters at the max. And these differences, they also lead to a difference in the percentage of energy absorption in tumors of different size. So for instance, when we consider tumors smaller than 3 millimeters, for yttrium-90, only 26% of the energy will be absorbed in the lesion, whereas for lutetium, this will still be 88%. So, and this is in line with the paper of O'Donoghue of 1995, where he stated that using lutetium peptides, lutetium-labeled peptides, there will be a high cure probability in the small tumors, whereas for yttrium-90, there will be a high cure probability in the bigger sized lesions, and that probably the combination would lead to a good tumor response, a high cure probability in a wider range of tumor sizes. So this we tested in rats, bearing both very small and larger tumors, and we compared yttrium-90 octreotide versus lutetium octreotide in doses that gave the same dose, radiation dose in gray. So we injected the animals either with lutetium octreotide or with a lower dose of yttrium octreotide, or with 50% of both in the combination series. And what we found was that the animals that had the combination, shown here in the green line in the survival curve, had a better survival than the animals that had only yttrium-90 or lutetium-labeled octreotide. So the combination was superior, and it was great to see that in clinical studies, and the references that I showed here are not complete. There's more studies now, that also in clinical studies, the combination gives a significant longer median survival than only the yttrium-labeled octreotide in this case. Also, tandem therapy is being performed, so that's alternating forms of yttrium and lutetium-labeled peptides. So this is from the past, but also we would like to look at the future. So we have our own list of proposals on how to do better. And one of the important things is that we are convinced that we need more knowledge on the PRRT cellular mechanisms. So we heard already about the double-stranded break formation after lutetium dotaoctreotide in the DNA. So here's the irradiation, and here is your double-stranded break. And this will attract all kinds of repair proteins, like the 53BP1, to the break in the DNA, and these can be nicely stained using immunofluorescent techniques to detect these 53BP1 proteins. And we can visualize this, and we see these foci in the cells. This is a non-treated cell. The blue in blue is the nucleus, and you see the foci. And this is a cell treated with lutetium octreotide, and you see the increase, the huge increase in the number of foci in the cell. We can do this not only in single cells in culture, but also in tissue slices taken from surgical samples from patients. And Julie Nonnekens, postdoc in our group, she has optimized this technique for neuroendocrine tumors. So she gets the tumor from the surgeon, and she makes slices up to 4 millimeters thick, and she can culture them in tissue culture and keep them alive and in good shape for about 1 week. So during this week, we can perform PRRT and look at the responses to the therapy. Afterwards, the slices can be embedded in paraffin, they can be sliced into histological slices, and they can be stained, and we can look for DNA repair. So we do comparisons of the human tumors versus xenograft slices to optimize the techniques. And finally, we aim to use this technique for determining the radiosensitivity and also for combination with the genomic techniques that have been presented earlier today. So these are studies in cells that she did. So here Julie looked at the double-stranded break formation by lutetium dotatate in cells. She gave a pulse of 4 hours of lutetium dotatate, and then she washed the cells and gave fresh medium without radioactivity, and at certain time points she fixed the cells and she looked for DNA damage and repair. Afterwards she quantified all the foci, and what she found that after lutetium octreotide there was an increased number of foci at day 0, day 1, 2 and 3, but not anymore at day 4, 5 and 6. So apparently all the DNA damage was repaired at these time points. So the question, of course, was that we wondered, how can we prolong this damage to the cells? And then we have to realize that lutetium makes double-stranded breaks, but the majority of damage to the DNA is single-stranded breaks that can be repaired easily. But there's a way to transfer single-stranded breaks into double-stranded breaks, and that's by inhibiting PARP that's involved in the repair of the single-stranded break. So if we use a PARP inhibitor, which are used in the clinic, for instance in breast cancer therapy, then this single-stranded break will not be repaired, and upon replication of the cell it will become a double-stranded break, which is more difficult to repair, and tumor cells might die. So Julie did her whole protocol again. She did again a 4-hour pulse with lutetium octreotide, and then she washed the cells. There was no radioactivity anymore, apart from the radioactivity that was internalized into the cells, and then she added the PARP inhibitor, and she looked again during 6 days at the number of foci in the cells. And what she found was that the combination with the PARP inhibitor, in purple here, had a higher number of foci in the cell, gave rise to a higher number, but also for a longer period. All 6 days of the experiment, the DNA damage and repair was ongoing, so there it was still present in the cells. So this was a nice way to improve the DNA damage and make the therapy work better. So there was more DNA damage after combination with PARP inhibitors, and this has to be confirmed now in vivo in animals, and we would love to have this confirmed in clinical trials as well. So another way to improve PRRT is to have better analogues, and the antagonists have been mentioned a few times already. They cause quite a paradigm shift because they do not internalize into the cells, but nevertheless they have higher uptake because there's more binding sites, And despite the fact that they are not internalized, there's still longer retention of the radioactivity in the cells. So that sounds like a miracle. This is also shown here. We have these cells that have somatostatin receptors which are fluorescent, so that you can follow upon binding of the agonist or the antagonist. So here is non-treated cells. In blue, again, the staining of the nuclei. And here you see after binding of octreottate, we see all the receptors clustering in the cell. And it's nice that in combination with the staining of the nucleus, we can see it's really around the nucleus, so the radioactivity is really close to the nucleus. And when we do co-staining with the Golgi, we see this is really the Golgi where it's located. And here is the antagonist, and we see that still the fluorescence is all over the surface of the cell, so there's no internalization. But despite this, if we give the same dose to the cells, we see that the number of double-stranded breaks, here the orange bar, after the antagonist, the JR11, is higher than after the agonist. So this is very interesting, and we also found that we could translate this to the in vivo situation in animals, that we had a better therapeutic outcome after the same dose of lutetium JR11, which is the antagonist, versus the agonist lutetium octreottate. So the antagonist labeled with lutetium led to a higher accumulation in the tumor cells and higher irradiation effects, so more double-stranded breaks. And this is to be confirmed. We also saw that in the mice in comparative randomized clinical trials. There was this interesting pilot study that has been shown before today, that in a limited number of patients, a low dose lutetium dotatate was compared with lutetium dota JR11, the antagonist, and the isodose curves showed us that the higher dose was obtained with the antagonist, and also there was a higher tumor to organ dose ratio. And afterwards, this group went on with the high dose therapy with the JR11, but there was no comparison yet with the agonist, and it would be interesting to see this also in clinical studies now. So what I try to tell you is that these preclinical studies, they can help us in the characterization of tumor response. We can use neuroendocrine tumor samples, as I showed you, or xenograft tumor models. In vivo, in vitro irradiation effects can be obtained. They can tell us about radiosensitivity of different tumor samples or different tumor types. They can give an estimation of the dose limits to normal organs. We can investigate repair mechanisms of the DNA, the kinetics of DNA repair and pathways of repair, and perhaps inhibitors of these pathways can help us to improve therapeutic effects in the patients in order to finally have the optimized treatment schedules for our patients as well, and aim for tailor-made therapy. Last but not least, I would like to thank my colleagues and former colleagues in our department, and I would like to thank you for your attention.
Thank you very much, Marion. Beautiful piece of radiobiology, and there's not many groups doing that kind of work, and I think it's going to be increasingly important. Do we have any questions? Yes.
Thank you for your nice talk. Could you comment on your experience working with human-derived neuroendocrine tumor in cell culture or animal models versus transfected non-neuroendocrine tumor cells transfected to overexpress somatostatin receptor?
Yeah, the main problem is that we do not have so many nice models available for the preclinical studies. So we are a bit struggling there, and that was one of the reasons that we, for prostate cancer, for instance, or breast cancer, we have so many models for different types of disease and different stages of disease, but for neuroendocrine tumors it's much more difficult. And also, if you have a good model, like there's a few that seem to be quite good, they are proliferating so slowly that the experiments become very, very expensive. So that's one of the reasons that we went into this tissue culture of the human samples, which is also not that easy because the tumor is quite rare and we do not have that often the samples, so we really try to use them as good as possible.
I Don't see any other hands going up, so maybe I could just finish with one question.
Excuse me.
Your work was very focused on the DNA and the
Yes.
cell nucleus as a target. What's your view on whether we should be looking also at other potential targets for radiation damage that might initiate apoptosis?
Another target like the membrane, you
The
mean?
membranes
Yeah.
or mitochondria?
Yeah,
whatever?
this is definitely something that we should look into as well. We did not touch it, but there's now so much evidence that we should also go into that we aim for that for future experiments.
We have another question.
Yeah, I just have one question. I mean, this antagonist question is so fascinating, and one of the questions that I'm wondering is the lutetium also, or the radionuclide also staying on the outside of these cells throughout
Yes.
the entire
Yeah.
6 days, or have you looked at whether it's internalizing at all?
Well, we don't know. We did not really test if it's not internalized at all, because all cells are, constantly internalizing medium, etc. So finally, if you leave the radioactivity long enough, or if it stays on the receptor long enough, it will finally be internalized as well. But it's not internalized via the same mechanism as the agonist. So it takes a much longer time.
One more.
Excellent talk. I just was wondering, do you think the PARP inhibitors are going to be selective? In other words, are you worried about a risk of overall increasing radiosensitivity in other tissues? I mean, in other words, so you can increase radiosensitivity quite a few ways, but if it's not selective, it may not be so beneficial.
Yes, we just took one from a company that we have a collaboration with already. What we tried to do here is that we gave the lutetium octreotide and then we washed it away, and then we came with the PARP inhibitor. So we do not aim for the same administration at the same time. I cannot see you. I only see a shadow because there's a lot of backlight. Sorry.
It's for the best.
Yeah, but so we think we should aim for injection of the lutetium octreotide and then wait. And then only after washout of the blood, then we can start with the PARP inhibitor. So when the lutetium octreotide is internalized already.
And then probably everybody else knows the answer to this question, but I didn't get it. You said there were more sites for the antagonist than the agonist. Could you elaborate how that happens? Please?
We are not fully sure. We are planning to investigate that. The theory is that the agonist only binds to the receptor when it's coupled to the G protein, because this is needed for the internalization process, whereas the antagonist probably can also target the receptors which are not coupled yet to the G protein. So there's a larger pool of that, so there's more binding sites. And for instance, we tested it on many tissue samples now. For breast cancer, we saw up to 53 times higher binding of the antagonist over the agonist.
Okay, thank you very much indeed.